Welcome to our first lecture this morning, Jakarta Endocrine Meeting from Division of Endocrinology, Metabolism, and Diabetes of Fakultas Kedokteran Universitas Indonesia and RSCM. I'm very glad here to be a moderator on this session. Our topic this morning is male hypogonadism, and my name is Roy Panusunan Sibarani. I am an endocrinologist from EMC Healthcare Sentul, Bogor. And our lecturer is nothing than Dr. Michael Irwig. Dr. Michael Irwig is an endocrinologist from Beth Israeli Deacon's Medical Center, Boston. It is an academic medical center located in the heart of Boston, and it is affiliated, teaching affiliation to Harvard Medical School. And I really want to present Dr. Michael Irwig, and he's very good in this area. And one a little housekeeping thing, please type your question for the speaker in the Q&A session, and there will be a Q&A session following this presentation. So I have to turn it over to Dr. Michael. And Michael, please start your presentation.
Okay, I'm going to share my screen. All right, so hopefully you can see my screen. Thank you very much for that kind introduction and for the organizing committee for inviting me to participate in this meeting. I have to say it's very special for me because my first international talk was back in 2005, and it was at the Sangla Hospital in Bali, Indonesia. So it's wonderful to have a second opportunity to interact with some Indonesian doctors. So this morning I'm going to be speaking about myths in male hypogonadism. And I just want to mention that I do not have any disclosures. I do not accept any money from the pharmaceutical companies, so I get to say whatever I want about any of the products. So I want to talk about some of what we're seeing in our clinics, which is probably happening where you are as well as here in Boston. So it's very common for men to have symptoms of fatigue and low libido and erectile dysfunction. And in today's age, people get on the internet, and they often will come across websites that list something called low T, which stands for low testosterone. And a man will often think, oh, I have all of these signs and symptoms, I must have a low testosterone. So then he often goes and sees his doctor, and maybe his general doctor or an endocrinologist, because he wants to have a testosterone test done. And very often, a lot of times, the result that we get from the total testosterone is going to be close to the lower end of the reference range. So it may be a little low or close to the limit between low and normal. And in the man's mind, he's made the diagnosis because he has the signs and symptoms. He sees that his testosterone is a little on the low end, so he thinks that this is confirmed androgen deficiency. So in his mind, all he has to do is start testosterone therapy, and then he can live happily ever after, and all of his signs and symptoms can go away. Now, unfortunately, this is not how things work in reality, and I'm going to go through some of the specifics about the different areas here. So the outline of my talk, we're going to be going over some of the non-specific signs and symptoms, the diagnosis of male hypogonadism, the management and monitoring of these patients, and I do want to point out some unethical practices that are going on out there. So let's start out just with the non-specific signs and symptoms of male hypogonadism. So a lot of men come to our clinics thinking that if they have a lower testosterone level, they're going to lack focus, they're going to be fatigued, they're going to have gynecomastia, abdominal fat, they're going to be depressed, less muscle mass, sexual dysfunction, and a decrease in their athletic performance. Whereas men who have higher testosterone levels, they're more confident, they have a better mood, they're more mentally focused, their heart is healthier, they have more muscle, less body fat, better sexual drive, and they can do better at the gym. And according to this picture here on the right, you can see men with higher testosterone levels even have a more masculine looking jawline. Now, it turns out there are very few signs and symptoms that are very specific for androgen deficiency. So if a patient has not gone through puberty, for example, if it's incomplete or delayed, or if a man loses, body hair, axillary and pubic hair, or if the testicular volumes are very small, so less than 6 ml, these are definitely indications to check a testosterone level. Now, some of the more suggestive signs or symptoms are things like a low sexual desire, a decrease in spontaneous erections or erectile dysfunction, and gynecomastia, infertility, low bone density, hot flushes and sweats. And then there's a whole bunch of symptoms that are just very nonspecific. So things like low energy and a depressed mood, poor concentration, sleeping problems, increasing in body fat, for example. Now, I want to point out that there are a lot of causes of erectile dysfunction other than low testosterone. So low testosterone is a very small number of men who have erectile dysfunction. Most of erectile dysfunction is due to aging, or it's due to vascular disease. But it can also be due to depression, anxiety, other endocrine disorders, heart disease, medications such as blood pressure medications, antidepressants. It can be due to alcohol abuse, narcotic or opiate use, diabetes, kidney failure, high cholesterol, high blood pressure, and chronic obstructive pulmonary disease. So there are a lot of more common conditions other than hypogonadism. And when a man comes to see me with sexual symptoms, so either low libido or erectile dysfunction, my first thing that I do is I want to look to see what medicines he's taking, because maybe it's a side effect of one of the medications. So here are just multiple classes of medications that are associated with erectile dysfunction, for example. So the anticonvulsants, the antidepressants, the newer ones, the older ones, antipsychotics, barbiturates, benzodiazepines, blood pressure medicines such as beta blockers, calcium channel blockers, diuretics, NSAIDs, anticholinergics, and antispasmodics. So there are many different medicines that can cause erectile dysfunction and low libido. And sometimes what we'll do is we'll try to take a patient off of some of these medicines to see if their symptom improves, because if it improves, then that tells us that it's most likely due to the medication, and maybe they can be switched from one medication to another. Now, when we ask patients about sexual thoughts, we often use the word libido in English, but a lot of patients actually don't really know what this word means and get confused by it. And it is quite a complex phenomenon. So sexual desire is a complex interplay between many excitatory factors in the brain, such as the dopamine system, norepinephrine, and oxytocin, and as well as inhibitory factors such as the serotonin system, opioids, and endocannabinoids. All right, now I'd like to speak a little bit about the diagnosis of male hypogonadism, and I call it the dreaded reference range, and you'll see why in just a moment. So just to review some of the basic physiology here. So in a normal adult male, the hypothalamus releases gonadotropin-releasing hormone, which then signals the anterior pituitary to release the gonadotropins, LH and FSH, which then stimulate the gonads, which in a male happens to be testes, and these produce testosterone and sperm. Now, primary failure refers to failure at the level of the gonads. So the testicles are not working adequately, and the pituitary is trying to stimulate the gonads to work more. So the LH and FSH are going to be elevated in primary. Whereas in secondary, the etiology is not at the testicular level, but it could be at the pituitary or hypothalamus with the signaling. And in this case, LH and FSH can be normal, or they may be low. Now, on this bottom panel here is a healthy 18-year-old man who has no medical problems. He's on no medications. He has a normal semen analysis. And what the study did is they looked at testosterone measurements throughout the day in this man, very frequently with each of these black dots. And you can see how the testosterone level changes a lot throughout the day. At one point, it was 251 nanograms per deciliter. Then it was 478 at another time point. Then it dipped down to 91, and then it rose up to 589. And why is there so much variability in testosterone? Well, it's due to the pulsatility of luteinizing hormone from the anterior pituitary. So there are these random pulsatile secretions of LH, which then signal the testes to release testosterone. And when there's a gap in these LH surges here, that's when the testosterone level can dip low. And this is why we always want to confirm a low testosterone with a second reading, because oftentimes that second reading is going to be normal, and we can reassure the patient that everything is working just fine from their reproductive axis. Now, when it comes to testosterone variability, there are some differences by age. So if we look at men who are older, who are age 58 to 82, this is in orange on the bottom, and we compare them with younger men in their 20s, we can see that there are some differences. So younger men tend to have higher levels of testosterone than the older men. But if we look at time of the day on the x-axis, we can see that for the younger men, on average, the highest testosterone levels were in the morning. So this is why we often will get testosterone levels in younger men in the morning and fasting. Whereas there are not as many differences in older men, so you probably don't have to do it in the morning for this population. So I do have a fun interactive question for you all. So here is your question of the day. So in a healthy 40-year-old man, what do you think the mean total testosterone level is in an average 40-year-old man? And the reference range I've put below, it ranges from 250 nanograms per deciliter to 1,050 nanograms per deciliter. Now, if you use different units, if you use nanomoles per liter, I put those numbers below here. So if you'd like to type in the chat, what do you think the mean testosterone level is in a 40-year-old healthy man? And let's see what answers we get. All right, so we have
All right.
we have a 15.6, a 450, and a 550. Perfect, very good. Yeah, so the mean level is close to about 475, 500. And why this is important is because a lot of younger men will come to see us and they think that their testosterone level should be, 850, 950 or something, like 30 or 33. And they think that that's where the testosterone level should be for a young man. And if their testosterone level is 350 nanograms per deciliter or 12 nanomoles per liter, that's more for an older man who's 70 years old. So we have to educate our patients that that's not how it works, that the mean testosterone level in a 40-year-old is closer to 475. Now, when it comes to measuring testosterone levels, we have different options. So the total testosterone refers to all of it. So most of testosterone is bound to either sex hormone binding globulin or to albumin, and only 2% is free or unbound. We have also some other ways to measure it. We have something called bioavailable testosterone. That refers to the free plus the albumin-bound portion, because when it's bound to albumin, it is loosely bound, so it can disassociate more easily, whereas to SHBG, it's more tightly bound. Now, there is a debate about which is a better reflection of a man's androgen status. Is it the total testosterone or is it the free testosterone? This is the same thing with things like thyroid hormone. Is it the free T4 or is it the total T4? So if you ask different endocrinologists, you'll get different answers. I'm going to point out one study that I like. This is from the European Male Aging Study, which had over 3,200 men aged 40 to 79. And what they did is they divided these men into 4 different groups based on their testosterone levels. So they defined a low total testosterone as less than 300 nanograms per deciliter, or 10.5 nanomoles per liter, or a calculated free testosterone was low if it was less than 220 picomoles per liter, or less than 6.3 nanograms per deciliter. And then the 4 groups were, both of them were normal, both of them were low, or there was a discrepancy. So I'm going to focus on the 2 groups where there was a discrepancy. So for the men who had a normal total and a low calculated free, this was associated with aging, comorbidities, an increase in SHBG, an increase in LH, a decrease in hemoglobin, a decrease in muscle mass, decrease in bone density on ultrasound, sexual symptoms, and physical symptoms. Whereas if you had a low total, but a normal calculated free, this was associated with obesity. And a lower sex hormone binding globulin was not associated with LH and was not associated with the sexual and physical symptoms. So according to this study, it's the free testosterone that was the more important one, because this was the one that was associated with an increase in LH, which is the regulation of testosterone, and was associated with the signs and symptoms. Now, when we look at the reference range, we have to know how it was determined. So the reference range is taking a group of the population and dividing them by these arbitrary percentiles. So typically what's used is the 97.5th percentile is used to define a high level of something, and less than the 2.5th percentile is considered low. And for total testosterone, the harmonized reference range is 264 to 916 nanograms per deciliter. Now we have to think, well, who were the men that define this range? Well, it turns out that the men used were healthy, they were aged 19 to 39, and they were non-obese. So this is not the general population. This is younger, healthy men who were not obese. If we were to use a general population, the reference range would be totally different. And the lower limit, if we use the same 2.5th percentile, would probably be much lower. It would probably be somewhere in the hundreds. So I want to point out that these cut points are arbitrary. They're not based on outcomes or on symptoms, but they're purely based on these percentiles. Now, there are some interesting studies that try to tease apart what level of testosterone is associated with, say, for example, a sexual symptom. So this was a study done in Boston at Massachusetts General Hospital, where they rendered men hypogonadal with a GnRH agonist, and then they replaced them with different doses of testosterone gels or placebo. So on the upper left here, you can see this is a change in sexual desire, and these are the different doses of testosterone on the x-axis. And on the upper right, this is sexual desire by the serum concentration of testosterone. So you can see that only when the serum concentration of testosterone was less than 100 nanograms per deciliter was there a statistically significant decline in sexual desire and in erectile function. But for men who had low testosterone levels in the hundreds or 200s, it was actually not statistically significant. Now, if we age adjust testosterone levels, we can come up with different numbers. So the Massachusetts Male Aging Study looked at reference ranges that were age adjusted. So here's the proposed normal lower limit for total testosterone. So it was 251 for men in their 40s, 216 for men in their 50s, 196 for men in their 60s, and 156 for men in their 70s. So clearly there's a big difference of a testosterone level of 251 versus 156. So something to keep in mind if you have an older patient, say a man in his 70s, and his testosterone level is 220, although it may be flagged as being low, it actually may be fine for other men his age. Now, there is a strong relationship between testosterone and body mass index. So this data, again, is from the European Male Aging Study. And if we look in the upper left, it looks at the mean testosterone levels by body mass index. So the green is healthy, the blue is overweight, BMI is 25 to 29, and the red is BMI is greater or equal to 30. So as compared with healthy men, men with BMIs greater or equal to 30 have on average a total testosterone that's about 25% lower. Now, the free testosterone levels can also be lower in men with obesity, and this is because testosterone gets converted into estrogen in adipose tissue via aromatase, and estrogen actually has potent negative feedback on the system. And obesity is also associated with a lower level of sex hormone binding globulin, so there's less protein that can bind to testosterone, and this also reflects why there was a lower level of total testosterone. And looking at it another way here, on average, overweight men have a total testosterone that's 66 nanograms per deciliter lower than men with a BMI less than 25, and men with obesity have a total testosterone that's 147 nanograms per deciliter lower than men with a healthy BMI. Looking at it even another way, overweight men are about 3 times as likely to have secondary hypogonadism, and obese men are about 8 to 9 times as likely to have secondary hypogonadism. Now I want to talk a little bit about functional hypogonadism. This is a term that I learned about when this paper came out in 2017. So functional hypogonadism refers to low testosterone levels in the setting of opiate use or excess glucocorticoids, high prolactin levels, chronic illness, obesity, diabetes, excessive exercise, older age. Whereas organic hypogonadism are the things that we probably learned about more in medical school, things like Klinefelters, Kalmans, and a pituitary tumor. And if you go looking for low testosterone, you're going to find it. So some studies estimate that up to 12% of adult men will have functional hypogonadism. So just to distinguish between these two, in organic hypogonadism, there is proven pathology at the level of the hypothalamus, pituitary, or testicular. And it could be structural, destructive, or congenital. Whereas in functional, there is no recognizable structural pathology. In organic, this is often irreversible, like Klinefelters, but in functional, it's often reversible if you get rid of the underlying cause. The signs and symptoms tend to be more specific with the organic, less specific with the functional. Testosterone levels in the organic tend to be lower and more consistently low, whereas in the functional, they can be more borderline. And the associations of a low testosterone with the symptoms are thought to be causal in the organic, whereas it's uncertain in the functional if the testosterone level is related to their symptoms. And the testosterone therapy is considered, the standard of care for men with, true organic cases of hypogonadism, whereas in functional, it's unclear what the risk-benefit ratio is of testosterone therapy. Now, the European Male Aging Study also attempted to define male hypogonadism. So this was an interesting study where they proposed using 3 sexual symptoms plus a total testosterone less than 317 nanograms per deciliter. And they defined the sexual symptoms as morning erections less than or equal to 1 in the past month, or getting and being able to keep an erection, never or sometimes, or sexual thoughts less than or equal to 3 per month. So if you had these 3 symptoms and a total testosterone less than 317, then they were diagnosed officially with male hypogonadism. Now, I like this figure here because it does tend to show at what level of testosterone is associated with a higher probability of having a sexual symptom. So if we look at the blue line, this is a decreased frequency of sexual thoughts. And you can see that the probability of having a lower libido goes up when the total testosterone is less than 8 nanomoles per liter, or 231 nanograms per deciliter. So that tells us that maybe that's a cut point of where testosterone may be associated with signs or symptoms. And likewise, they put in here for erectile dysfunction, there seems to be a little bit of an inflection point around 8.5 nanomoles per liter. All right, now we're going to talk about testosterone therapy. So a 30-year-old man is referred by the nurse practitioner for a consultation regarding management of several symptoms over 3 to 4 years. He's had a low libido, nervousness, fatigue, cold intolerance, confusion, insomnia. He went through a normal puberty. He's single. He's not attempted to father any children. He denies any causes of primary or secondary hypogonadism. He does have a high cholesterol. He's on a bunch of mind and memory supplements, but no prescription medications. His body mass index is 27, and his physical exam was pretty unremarkable. It was a little unclear if he had a little pseudogynecomastia. So when he came to see me, he already had his blood tested, and here are the results. We have the total testosterone, free testosterone, bioavailable testosterone, estradiol, LH, and FSH. And you can see the reference range in parentheses. So these were all within the reference range. So think about, what would you do for this man if he came to see you in your clinic? So we saw his signs and symptoms, and here are his levels. So this is what I did. So in my men's health clinic, I administer a depression screen. I like the Patient Health Questionnaire 9, which is 9 questions. And it basically asks, over the past 2 weeks, how often have you been bothered by little interest and pleasure in doing things, or feeling down or hopeless, falling asleep, feeling tired, feeling bad about yourself, and even suicidal thoughts? And there are 4 different scores. 0 is nothing, to 3, which is nearly every day, and then you add all the numbers. And a score greater than or equal to 10 has a sensitivity of 88% and a specificity of 88% for major depression. So this particular patient who I saw scored 24. He had severe depression. He actually wrote down that he had thoughts that he would be better off dead or hurting himself, greater than or equal to half of the days. And I was quite surprised that this never came up during the interview with him. He never told me he was depressed, never mentioned this at all, and I only uncovered this by having him fill this out. And a lot of patients are embarrassed or to talk about things like depression, but it is real and it is very common. So I suggest using some screening instrument in your clinic. A few years ago, we did this study. I had a medical student do a chart review of 200 men who presented to my clinic with borderline testosterone levels. So men who had a total testosterone between 200 and 350 nanograms per deciliter, or 6.9 to 12 nanomoles per liter. And if you look at these men, who were they? Well, it turns out that over half of them were not exercising at all. Only 16% had a normal body mass index. About 39% were overweight, 43% were obese. So over 80% were either overweight or obese, and about 56% had depression, or they were on an antidepressant, or they scored at least 10 on the PHQ-9. So you can think about it as 2 different buckets. A lot of men with these borderline testosterone levels are going to have the overweight, obesity, and or depression. Now, the good news is that if a man with obesity loses weight, his own body will make more testosterone naturally. So on the x-axis is the percent body weight lost, and then the y-axis is the increase in total testosterone. Men who undergo bariatric surgery, as seen in these gray circles, have a tremendous increase in their testosterone because they can lose a lot of body fat, sometimes 20 or 35%. But even if a man is able to diet and exercise, by losing 10% of his body weight, his total testosterone can go up by about 86 nanograms per deciliter, or about 3 nanomoles per liter. Likewise, sleep is associated with low testosterone levels. So men who are partially sleep restricted, who sleep only 5 hours a night in a hospital setting, were found to have 15% lower testosterone levels, as shown in the dotted line, as compared to men who were sleeping 8 hours a night. So you do want to ask your patients how many hours they're sleeping. Now, unfortunately, lifestyle is very difficult for a lot of our patients. A lot of patients are unable or unwilling to make a lot of major changes to their life. And a lot of people just want a quick fix. So they may just want to take a pill or have a surgery. Now, the good news is that there is a lot of help available to us. We don't have to do this all on our own. So if you have a man with obesity, you can work with a nutritionist, have him join a commercial weight loss program. He can hire a personal trainer. He could use a pedometer. He can get on an obesity medication. For depression, we have therapists, we have psychologists. For sleep apnea, we have sleep specialists, we have CPAP. And for men with severe sexual dysfunction, a urologist can give other medications, such as injections, if a man does not respond to a PDE5 inhibitor, for example. Now, here are some of the different testosterone formulations that are out there: the intramuscular, the patches, the gels, the buccal, pellets, nasal spray. We also have an oral. They're all given in different ways, and none of them is necessarily better than another. I'll just highlight to you that most of my patients are on the esters or on the gels. What I like about the esters, at least in the United States, is they're very cost effective. So they are the cheapest by far. They're given every 1 to 2 weeks, either intramuscularly or subcutaneously. You do have peaks and troughs, so the patient has to know when they injected the testosterone. There sometimes can be a little bit more pain with the IM sites. It's a little more slightly at risk to cause erythrocytosis than the other formulations. We also use a lot of the gel here. That's applied daily to their skin. In the United States, it's much more expensive. Transference is only if a guy puts the testosterone on his hands, and doesn't let it dry and then touches a woman or a child and then it gets into them and then it can cause problems. So as long as a man washes his hands, lets it dry on his skin and then puts on a t-shirt, he should be fine. And then some of these other formulations are not as commonly used. And in the United States, a lot of them are not covered well by insurance, so they would be quite expensive for our patients. As I mentioned, for those on the intramuscular or subcutaneous routes of testosterone, you want to check when he took the testosterone dose, because a few days after the dose, it's going to be a peak, and then the trough is going to be the lowest point. So this could be a week or two after an injection. Now, are there any adverse effects of testosterone? Of course, there are adverse effects of pretty much every medication. So testosterone may cause erythrocytosis, acne and oily skin, detection of subclinical prostate cancer, which means that men who get put on testosterone get PSAs checked more often. So that's why some of them are going to come back high and they're going to be found to have prostate cancer. We don't want to give testosterone to men who have metastatic prostate cancer because it is thought to add fuel to the fire and worsen metastatic prostate cancer. And testosterone can cause infertility by negative feedback and shutting down the reproductive system. I do want to point out some unethical practices. In the United States, we have a lot of companies online that are trying to target younger men and middle-aged men by saying, who can have a low testosterone? Anybody. And they say low testosterone is a natural part of aging. We can change that. You don't have to feel tired. Start feeling like yourself. All you have to do is get on testosterone. We also have things like low T centers that are started by business people, not by doctors. And they advertise a new approach to men's wellness. They claim that they're reinventing men's health care to prevent, slow, or eliminate serious health issues. But this is really not true at all. They're just trying to put as many men on testosterone because that's how they get paid and that's how they make money. In fact, they were bringing in men for injections every 7 to 10 days because they could bill the insurance company when they gave an injection. There are even online companies here in the United States where you can prick your finger, put a drop of blood on a card, mail in this card, and they will check all your testosterone levels, and you can have a video consultation with a doctor, all for $45. And often what happens is that they're going to recommend either testosterone or HCG or clomiphene, etc. And in the United States, a man would pay probably about $1,000 to $2,000 a year just to get these medications from this company. And unfortunately, this is not about the best health of the patient. This is all about money and profit, because this is a business. So you may have some of this in Indonesia as well. My guess is you may have some patients who want to get on testosterone because they want to look better and have more muscles, and they want to help you, and they want you to help them do that. There is a position statement by the American Association of Clinical Endocrinologists called Off-Label Use and Misuse of Testosterone, Growth Hormone, Thyroid Hormone, and Adrenal Supplements, Risks and Cost of a Growing Problem. It's a huge industry. Billions of dollars are spent on all of these supplements, many of which do not have any evidence behind them. And this is freely available online, so you can educate your patients, have them read about this if they have more questions. Well, what do the randomized controlled trials show? What's the evidence of testosterone? Do men live happily ever after? So the American College of Physicians commissioned this study where they looked at randomized controlled trials as well as observational studies, and they calculated the standardized mean difference, where small indicates a small effect of the testosterone, that's about 0.2, a medium effect was about 0.5, and a large effect would be a 0.8. So if we look at global sexual function, the certainty of evidence was moderate that it had a small to medium effect. For erectile function, low certainty of evidence that it had a small effect. Physical function, low certainty of evidence that it had a small effect. And quality of life, low certainty of evidence that it has a small to medium effect. So testosterone is not the miracle medicine that a lot of people are hoping it's going to be. And it often does not do things for some men. So basically, this comes down to clinical judgment. If you have a man with a borderline low testosterone levels, ask yourself, could he have obesity? Could he have sleep apnea? Is he snoring? Is he sleeping enough? Could he be depressed? Is he on a medication that could have a side effect? And for a man with a borderline low testosterone level, one option is to give him testosterone. That could worsen his cholesterol by lowering his HDL. It could worsen his blood pressure. There's no evidence that it's going to improve his cardiovascular health. It may slightly reduce his risk of diabetes. There's no evidence it's going to reduce his risk of cancer. It may cause infertility, and it may cause erythrocytosis. Whereas if you can get this man to exercise and lose weight, that's going to help him with all of these things, with his cholesterol, blood pressure, sleep apnea, survival, diabetes risk, risk of certain cancers, and it's not going to cause infertility. So certainly do exercise and weight loss as the first line whenever possible. So in conclusion, here are some take-home points. So for functional hypogonadism, there's uncertainty whether the signs and symptoms are related to testosterone. It may be reversible. There's an unclear risk-benefit ratio with testosterone therapy. There are limitations to the reference range. The reference range may not be clinically meaningful. Keep in mind it's not age-adjusted. There's uncertainty whether the total or free is the better reflection of androgen status. Men with borderline low testosterone levels often have overweight, obesity, and or depression. So you want to use a discretion screening tool. And I like to address the reversible causes rather than just making a number look good on paper and turning a 220 testosterone level into a 400 just by prescribing testosterone. So I'm happy to leave some time for questions. I also have my email here, so you're welcome to be in touch with me via email. And, I do hope to meet you in person someday, maybe in Indonesia next year, or if you come to Boston or at the Endocrine Society in Chicago. So I'm going to stop sharing my screen, and we're going to open this up for questions. Thank you very much for having me.